Afternoon and welcome to the School of Public Health. We are observing the World Health Day today, which is 7th of April. I think all of you know why 7th of April is World Health Day. Any idea? That is the day WHO came into being. So it is in troubled times now, but let's see. So 7th of April, WHO was formed in 1948. So from that year onwards, every year 7th of April is observed as World Health Day with a particular theme. And for this year, the theme is Healthy Beginnings and Hopeful Futures, which is also a very difficult theme to conceive. But what it essentially says is health of mothers and babies is the foundation of healthy families and communities, helping to ensure hopeful futures for us all. Basically, it is looking at mothers and babies and their foundational health care. So as I said, it is on 7th of April. It will kickstart a year of campaigning. And it is mostly an advocacy event to urge governments and the health community to ramp up efforts and end preventable maternal and newborn deaths. See, unlike some of the chronic diseases, a large number of these conditions are preventable. So I think action has to be taken. Tragically, based on current published estimates, close to 300,000 women lose their life due to pregnancy or childbirth each year, while over 2 million babies die in their first month of life and around 2 million more are stillborn globally. That means roughly one preventable death every 7 seconds. So based on current trends, and you know that there are SDG goals, 4 out of 5 countries are off track to meet targets for improving maternal survival by 2030. So these are the main things: investing in maternal health, work on global targets, quality and respectful care for all women, and also care for babies. WHO has already developed this. I'm sure experts sitting here know this. Strategies towards ending preventable maternal mortality, and there are a lot of actions proposed for that. I was just looking at MAHE's announcement of this birthing simulator at Kasturba Medical College, Manipal, which is good, which is the state of the art in the world. But just a few kilometers away, we will have places like this also. So that is why we need to change. Like islands of excellence are there, but maternal mortality is not just an issue of a particular hospital, it is of a whole place. Similarly, for essential newborn care also, we have various parameters. I'm sure Dr. Leslie and others will talk about that. There again, there is a huge world of difference what is newborn care in some of the high-end hospitals and what is the average hospitals. So with that, if you look at it, I'm sure there is more recent data. You can see the variation in infant mortality rate and in maternal mortality rate in India across different states, which still shows that a huge amount of work is needed. There are states with single digit. Karnataka is also reasonably good. Tamil Nadu is doing very well these days in maternal mortality, but infant mortality is still many red areas also in the country. So a lot of work needs to be done on that. You know, global burden of disease, it's very interesting. Sorry, it's too small to read, but what it actually shows is what are the major causes of maternal mortality and in different states. This is the rate, as well as these small bars actually shows maternal hemorrhage, maternal sepsis, maternal hypertension, and various other conditions. So it is still, I think Karnataka is somewhere here. So that is the variation within India with regard to the various causes. So with that, I think the campaign goals, as I said, is to raise awareness about gaps in maternal and newborn survival. I think that is something that we need to know. When we sit in a very nice hospital, we think that we are doing great, but as I said, we need to know that there are substantial gaps in this area. And advocate for effective investments and encourage collective action to support parents as well as health professionals and useful health information relating to pregnancy, childbirth, and the postnatal period. So that means we have a scope of work under this theme to look at right from good nutrition, because I always think that if you want to have good next generation, the best thing investment should be investment in adolescent girls. Because if healthy babies are born, they will even have less NCDs as they grow. So right from nutrition, good antenatal care, emergency obstetric care, newborn care, and follow-up support. So with that, I will stop, and then maybe we'll start with the panel discussion. So what is interesting is that we have this very interesting panel, which is going to cover multiple facets of what I have just started with a glimpse. Maybe I'll start with Dr. Ranjitha Shetty, Professor of Community Medicine, and congratulations for your new position also, Associate Dean. So what are the trends in MMR and IMR in India, and what are the main drivers of this change?
Hello everyone. At the outset, I would like to thank Dr. Cherian Verghese, Director PSPH, and the PSPH team for having me here for today's panel discussion. So on today, the World Health Day 2025, as we reflect on its theme, this year's theme, that is Healthy Beginnings, Hopeful Futures. So it's important for us to recognize like how far we have come in improving maternal and child health, and also to know how far we still need to go to achieve the targets. So if you see any country's overall healthcare system, which needs to be assessed, that there are two important indicators, sensitive indicators, that is maternal mortality ratio and infant mortality rate. So India has made a significant progress in maternal and child health. As Sir also has mentioned just now, that MMR has dropped from over 500 in the 1990s to almost 97 per lakh live births in 2020. This is a remarkable achievement, but still like in India, around 24,000 women lose their lives to maternal causes, which is actually a preventable tragedy. And we need to look at this like, because majority of the deaths are mainly due to the causes like postpartum hemorrhage, infections, hypertensive disorders, or abortion-related causes, and also complications during labor. So as we say, like there is a remarkable decline in MMR, we also have to acknowledge that there is regional disparities. Like while Kerala, which reports around 30 maternal deaths per lakh live births, there are states like Assam, which are still reporting about over 200 maternal deaths per lakh live births. So this requires a targeted and context-specific interventions in these underperforming regions. And similarly, infant mortality rate, if you take, we have made a significant achievement, which was about 58 in the year 2005 per 1,000 live births, which has come down to almost, there is more than 50% decline. It's around 27 per 1,000 live births now. And as Sir has mentioned already, majority of the deaths are happening during the neonatal period. That is the first 20 days life of the child, 0 to 28 days. So that is mainly because of the prematurity or low birth weight and other acute infections. So having said that, all these achievements we have, like India has progressed towards, we are on the track of achieving the target for national health policy for maternal mortality rate, which is less than 100 per lakh live births. And we are also on by 2020, and we are also on track for SDG target 3.1, which says that our maternal mortality ratio has to be brought down to less than 70 per lakh live births. So almost 9 states have achieved national health policy goals on this, and 7 states have also achieved SDG goals. So that is a remarkable achievement. So the major drivers of these changes are mainly the programs like RMNCH plus A, what we have. In addition to that, we have initiatives like Janani Suraksha Yojana, which has been launched in year 2005. We are completing 20 years this year actually. And Janani Shishu Suraksha Karyakram, they have ensured the logistic and financial support for institutional deliveries. So institutional deliveries have been enhanced and numbers have increased. And there are other initiatives, programs like Universal Immunization Program and ICDS, Poshan Abhiyan, which all have taken care of immunization and nutrition, malnutrition, which tackles, these programs tackle those issues. And then newer initiatives like PMSME, that is Pradhan Mantri Surakshit Matritva Abhiyan, and Suman, or Lakshya, that is labor room quality improvement initiatives. And so many initiatives have been implemented. The public health strategies have been implemented effectively and efficiently by the Government of India. So all this achievement could be made possible. And also in addition to that, we also have like female education. Literacy has improved, and teenage pregnancies have come down. And also like other intersectoral coordination, like road connectivity has improved in many places, though we have areas like where it is still a challenge. So these also have played a crucial role in making this progress possible. So on this World Health Day, like we need to look at like what are the challenges we still have to overcome. So as I mentioned earlier, like the states like Uttar Pradesh, Assam, or Chhattisgarh and West Bengal, they still need focused attention by the health system, and so that we can achieve further progress and reach the target of by 2030, the SDG target. So on this World Health Day, like we all should agree that any healthy beginnings plants a seed for hopeful future. So as maybe as a policy maker or healthcare professional or even as a citizen, everybody's action can save lives. So that's what, with that, I would like to conclude that like we should empower every mother and support every newborn and ensure that everybody's nobody's left on their journey to health and dignity. Thank you.
Thank you, Dr. Ranjitha, for beautifully covering. I think not only every mother should be empowered, every father should be empowered, because it is usually the father who causes part of the problem. And also you have clearly shown that there is substantial decline, but I think you highlighted the fact that the progress is not even. Even in Karnataka, the progress is not even. So I think there is a lot of work that needs to be done, and especially in ensuring adequate antenatal care and ensuring a safe delivery. So we have none other than Dr. Prashanth Adiga, Professor and HOD of Medicine and Surgery of KMC Manipal. So sir, can you sort of elaborate on how can we ensure, I know your department is excellent, but I'm saying how do we ensure an adequate antenatal care and ensuring safe delivery across the board?
Thank you, sir. At the onset, I would like to thank Dr. Varghese. As he rightly pointed out that the health services are not uniform in the state nor in the country. In the undivided Dakshina Kannada district, the maternal mortality and perinatal mortality are comparable to the Western world. I had the opportunity of working in northern Karnataka, where in fact 80% of the women would be anemic. So if I compare, I mean it's not a comparison, it's just to make us understand what is the difference between here and that place. Probably education is one of the most important aspects. If a woman is educated, she understands the need for antenatal care, she understands the need for regular antenatal visits, and of course institutional delivery. In this part of the world, institutional delivery was almost 100% about 20 years back. That has made a major impact in reducing the number of maternal mortalities. And then coming on to the accessibility of healthcare. Now, even though the number of abortions have come down, many women would go for septic abortions because they would go to a quack, and then they would, there would be some intervention, and by the time they come to the tertiary care center, she would be in a very bad state. But that has improved. But what are one of the major things which is education, and second thing is we have to, with the help of the community, with the help of the leaders in the village or in the community, we can propagate the need for regular antenatal visits. Of course, now with the advent of the many programs which Dr. Ranjitha has said, that people have been having access to antenatal care. And one of the major problems is anemia. One is it is because of nutrition. Second is about the taboo. Even though the patients are given iron tablets, they have a taboo that when you take iron tablets, the baby is going to grow big and they will need cesarean. They give the tablets to their grandmothers, which is very, so probably, and the other thing is, probably these patients need frequent testing of anemia, because here also many times we have seen that patients have postpartum hemorrhage, and then somebody whose hemoglobin is 8 or 7, by the time they reach the hospital, they are either dead or they're in a very serious. So anemia is one of the major concerns, along with, of course, anemia and malnutrition go hand in hand. And of course, we have to screen for preeclampsia. Preeclampsia, again, this is one of the major killers, as Dr. Verghese told, that along with anemia, sepsis and hypertension. So hypertension is, again, you can't prevent it, but it has to be diagnosed early. And of course, once it is diagnosed, then it has to be referred to a higher center. These patients need to be cared at a higher center where there are adequate facilities to treat them. And of course, malnutrition, anemia can predispose them to preterm labor, which is again one of the important aspects. Probably in this Anganwadi, this particular aspect is taken care of. And the fourth problem which we have encountered is post-dated pregnancy. Many times we have expected date of delivery where the patient is expected to go to the hospital. But again, they do not go because they wait for the spontaneous onset of labor. And by the time the patient comes, again there might be fetal distress or stillbirth. And the most important is the community. Of course, you have got these Anganwadi workers, which they have been doing a great job, but again, it is the participation of the community per se. It is a participation of the individual. So, probably, again, as Sir said, educating the daughter or educating the adolescent girl is going to be the real, game changer in future. Adolescent, educate her, treat her well, and that is where it is going to have an impact. In fact, even in schools, they have been taught about education, and sensitizing them in the schools are going to help. So probably, the situation is much better, but there is always room for improvement. And of course, with the help of social media, immunization used to be a big problem, because when I was studying, there used to be a lot of tetanus. So now, with a lot of campaigning in the TVs, now with the advent of social media, it should be much easier. Of course, there can be many other things which can be done, like with the help of WhatsApp or any of the social media, tell them the 10 rules, rule of 10 hours of sleep, 10 grams of hemoglobin, then 10 hours of rest, then 10 movements a day. By that, you are able to incorporate these aspects so that the patient can come to the regular antenatal visits. In case their hemoglobin is 8, then yes, they can go to the doctor and say, I should be 10. Why is it? What can be done? With these few steps, probably we can improve. But the most important thing is education. Especially that should start from the adolescent girl and of course the father also, as you rightly said.
Sir, are there any financial?
Yeah, financial barriers are there. For example, again, when there are women who are multigravida, they have 2 or 3 children. They are working women. And, by the time, they are coming to the antenatal visit means loss of pay for that particular day. That is one important aspect. So probably a time might come where, this is especially true when the patient is, anemic. In fact, when I was working in North Karnataka, the patient would be having 3 children and her hemoglobin would be 7. So coming to the hospital and taking injection means that day she would lose her earning. And of course, they think that more number of children, they are going to earn more, which may not be always the case. And then these are the risk factors for having maternal morbidity and mortality later on.
And also to have low birth weight babies who will then continue to have problems. So coming to that, I think we have Dr. Leslie Lewis, Professor of Pediatrics and Neonatology of KMC. Sir is going to tell us how can essential newborn care be augmented at different levels of healthcare. So here again, an access is a problem, but again, a very high level of newborn care is needed at certain level. So how do we ensure that we can have access at different levels of healthcare, and how can that be titrated so that their needs can be met?
Yeah, thanks, Professor, for this opportunity. If you look into the infant mortality of Udupi district, 6 to 8 over the last 15 years, or maybe more than that, which is very comparable to any developed nation, better than that. 5 killers, as pointed out very clearly: preterm birth, neonatal infection, asphyxia, congenital malformation, and the genetic disorders. Last 2, we may not be able to do much, but first 3, I think we are doing a lot. Government has done a lot over the years. But as you pointed out rightly, it is not uniform throughout the health sectors, from the base level to the higher levels. Home-based care is one of the essential area where we need to do a lot of things to prevent the infant mortality. And I think we are doing very well in the home-based care. Our hospital deliveries, if you see, is almost 99.9%. Only 5 deliveries, that's what I happen to know, that it has happened at home. So at whatever cost, I think we should avoid these home deliveries. The moment home deliveries happens is kind of a risk for everything, for the mother as well as the baby. So in that way, I think if we can prevent rest of the other parts of the India where our infant mortality, maternal mortality is higher, if we can prevent this kind of the delivery is happening at home, maybe a one step for us. Breastfeeding, if you look, the rates is coming down. Both educated mother, uneducated mother. And it is sad to say that 60% of our educated, uneducated mother complete exclusive breastfeeding for up to 6 months, including good health care workers. Even the breastfeeds are there. And they feel that one dose of extra milk will benefit. I think it's a common practice. We're trying to break our head. We're trying to stop these practices. Enough milk is there. Baby is growing well, but still some additional milk. I do not know where this practice has come and how to break that kind of a practices. Looks to be, I think, where we need to work on that to prevent that. That is the second. ASHA workers are doing extremely well in the grassroots level. They identifying the problems and referring them early. Infection control practices has very well improved. In fact, neonatal infection, early onset infection is very less nowadays. Late onset infection is community acquired. Again, if you see Udupi district, we are not witnessing much compared to the last 5 years. So there we have done really well. Next to the primary health center level. Primary health center, not many deliveries are taking place. Only few centers in our Udupi district or Dakshina Kannada district, deliveries are happening in the primary health center. Maybe in a year, hardly single digit to a double digit. But they should be empowered to basic resuscitation, a basic newborn care, and the care of a baby as well as the mother. Because it's a practice that anything is there, go to the higher center or next to the private setup, rather than utilize the primary health center. We need to strengthen with the care of a delivery, care of a resuscitation. WHO has repeatedly says that immediate skin to skin care in normal deliveries has to happen. We are finding in a tertiary care to implement it. What about in the primary health centers? It has to be done. This is the best way. The immediately skin to skin care, thermal care is done there, infection control practices are in place, exclusive breastfeeding has been initiated, and that's a way to go. So primary health center, everybody has to be trained in this, including the delayed cord clamp. The moment it is the practice of a gynecologist that how early we can cut the clamp. Now we know that there's the evidence, everything has come in practice that delayed cord clamp for a baby's crying, breathing at birth has to be done. So these are the things at the the primary health center. Next is the community health center. Yes, good number of our community health centers are doing a good essential care. But again, they need to be supported with, again, a good birthing center, good resuscitation facility, and to take care of our babies at least the first 3 to 5 days after the birth. Many practices is that discharge the baby within 24 hours. That's a not good practice. Even if you see the ESI or insurance, they think that the moment you delivered, next send the baby home. But most of the primary mothers do not know how to feed the baby. And they come back to us with if you see in our district, climate change has done a lot of damage to our babies. Dehydration fever, one of the problems in our babies, we keep seeing starts from the January month till April, May month, a lot of babies being admitted with a dehydration, significant weight loss, going for a hypernatremia, acute kidney injury. Because the breastfeeding practices is less. Second thing is exposing the baby to a sunlight is a practice in our country. Expose the baby to the sunlight so that good vitamin D comes, and at the bargain of that, babies are being roasted in that sunlight, early morning sunlight. The feeding has not taken place and comes back to the admission to all higher centers. And this is throughout the coastal Karnataka, and it's happening in other districts where temperature is higher, not the cold temperature. So the community centers has to be strengthened. District health facility, essential newborn care has to be improved, which is not up to the mark in our Karnataka state. Most of the babies, they can manage. Any baby less than 2 kilos, any baby with respiratory difficulties, non-invasive ventilation is there everywhere. It's easier. A glucose monitoring, babies comes back to us with the hypoglycemia, and hypoglycemia-induced brain damage is much higher than hypoxic-induced brain damage, which can be prevented easily in the district health center and has to be strengthened there. I think somewhere we are lagging behind keeping these babies in the district health centers where facilities are there, but somewhere the manpower is there, but that kind of a commitments are not there to take care of these babies and give one extra step. And the last one, transport facilities. Lot of things has been done, but all transport happens at the last minute. High risk delivery has to be referred to a center where facilities are there. There's no point keeping them. Or many places it is like you deliver the baby, and once the problems are there, you send. Even preterm babies, they know that they cannot manage the babies, and I do not know what is the reason. Are they losing the patient? Mothers, because of that, they are not referring. We really don't know. Wherever the facilities are not there, high-risk deliveries are there, they should not take into that. They has to be referred. And transport happens at the last minute. We keep seeing a lot of babies coming from the neighboring district. The pediatricians calls to us that babies refer. By the time they reach here, babies died on the way. The transport facilities are not equipped to what is called as stable, simple things, sugar, temperature, A is airway, B is breathing, L is simple lab tests like a glucose, E is the counseling and emotional support. This is called a stable for a transport, which is not happening, even though we have a high-end transport system, but which is not taking place. So we need to concentrate on this, and if we improve, I think possibly we can do a much better in our country.
Thank you, sir. One follow-up question to both of you. In a district, if PHCs handle only 4 or 5 deliveries per year, do we still need to say that they should take delivery, or can all deliveries go to CHC so that slightly better care is offered? And also in neonatal care, which improves. So,
sir, I think they should take care of. And why they should send the normal baby to our tertiary care? Then we load it with the normal care only. Our area is to take care of the high-risk babies. And nowadays, it's the mandatory that even our undergraduates are trained for a newborn care. So it has to be taken care there. Even CBME has come into picture that they should be ready to take a delivery, normal deliveries, but which is not taking place. In fact, they should be given training, our interns, should be given a training for normal delivery and take care of this babies and take care of this normal deliveries in the PSCs.
Even if it is only 5 or 6 per year.
Yes.
Okay.
So, thing is, as he rightly said, low risk pregnancies may be delivered in the PSC.
Okay.
But in case we are anticipating high risk pregnancy, or in case the labor is not progressing satisfactorily, now we have partograms which will tell us how the progress of labor is. In case the labor is not progressing satisfactorily, you can always refer them early rather than referring them late when things are at a very bad stage.
Okay, so we heard from the experts. Now let me go to Dr. Jyothsna. Thank you, madam, for coming, and I know that you are the Reproductive and Child Health Officer for Udupi. Udupi district is doing very well, as we heard. There is no doubt about that. But when you do very well, then you are expected to do even more. So how can you improve whatever, highlight the progress already made, but also what else can be done in Udupi district so that it can be the model district for India?
Good morning, sir. Good morning, everyone. Thank you for the opportunity, sir. Since the introduction of the program, that is CSSM, Child Survival and Safe Motherhood, since 1992. So lots of improvement has been done in the program. Series of programs are added, like National Rural Health Mission, under which ASHA was created. Then National Urban Health and National Rural Health became a National Health Mission. So then there was Ayushman Bharat, which was introduced in 2018. So lots of improvements were done in infrastructures. So labor OT, labor room, labor OT was created in each and every primary health center. The main problem is human resources. So even government has made a provision to give EMOC training for medical officers, but still that program has not yet reached all the medical officers. So human resources is the problem. That is why, as Dr. Leslie sir and Dr. Prashanth said, there is no deliveries in PHCs and no deliveries in CHCs. So these are the main problem. So as per the progress we see from past 10 years, our progress is really good. 99.9% of institutional deliveries. Then our maternal mortality rate, except in 2021 and 21-22, which was 96. So last year we had only one community death, and facility we had some 5 deaths. So preventable were 50% 50% preventable, 50% not preventable. So we have very much improved in that sector. There is no death, PPH death in last 2 years. So that is one improvement. Then hypertensive death, only one hypertensive death we had. So that is due to late referral from other district. And one was sepsis. So these are the preventable deaths we had. And IMR is less than 10, infant mortality rate is less than 10 throughout almost 10 years. Trend, when I am checking, it is throughout less than 10. Except in 2021, maybe due to COVID, I am not sure. So it was 9. But last year, that was 23-24, our IMR was 6.8. And this year, that is 24-25, our IMR is 7.1. So the number of death is less. Even in infant mortality, if you see, the preventable death is very, very low. So out of, we had 80 deaths last year, only 20 were preventable. So preventive, even in preventable death, we have cases like premature. Premature may be due to twin pregnancies, IVF, all these things will lead to premature deliveries, and that will cause premature death. So we are trying to reduce this premature infant deaths. So already maternal death we have reduced in a very drastic level. So infant mortality also we are trying to reduce. We are focusing on preventable deaths, especially premature which can be caused due to hypertensive disorders in pregnancies. So that we are focusing on.
Do you see many hyperglycemia also in pregnancy?
Diabetic, we have, last year we have detected 131 cases of diabetics. We are focusing on high-risk pregnancies. We have PMSMA, EPMSMA program, which is conducted PMSMA every 9th of month, and 24th of every month we are conducting EPMSMA. So where we are diagnosing the high-risk pregnancies and treating the pregnancies. We have 121 diabetic patients and I think 141 hypertensive patients we have diagnosed. So thyroid, we had some 122 cases of thyroid, hypothyroidism cases we had. So rest all like twin pregnancies, then
And anemia is not an
multigravida.
issue.
Anemia we had only 22 cases.
Okay.
Last year we had diagnosed only severe anemia, I'm telling, less than 7 gram, we had only 22 cases. So these are the progress we have done in our district. It is an excellent progress.
No doubt.
So in collaboration with Kasturba Hospital, we are a team, sir. So gynecologist, pediatrician.
So that
So
I
we
can
are
see. I think
doing,
that seamless connect between these two entities
yeah, community
is really
medicine.
something good.
Yeah. So
Okay.
we'll be conducting meetings. We are doing committees, committee level meetings, subcommittee level meetings, including everything, even immunization. When we check immunization, our immunization coverage is 98% of all antigens. So there is no breakouts of any diseases, and as we know that polio is eradicated, so but we don't see any diphtheria, pertussis and tetanus cases from past 10 years.
Okay.
So these are the progresses what we have done,
Okay.
we have achieved.
Very good, ma'am.
Yeah.
Very good. But we also heard repeatedly that nurses have a major role at every stage, right from helping adolescent girls through antenatal care, through emergency obstetric care, through neonatal care, into breastfeeding and the following areas. So are they adequately equipped? What do you think, Ms. Shilpa Louis?
Thank you, sir, for the question. I, Mitchelle Lewis from College of Nursing. I specialized in obstetrics and gynecological nursing, and here in before me are esteemed panel experts who have been working very closely with reducing maternal mortality and neonatal mortality. But I would like to speak from a perspective of a nurse through my experience, where many problems have been already identified, and I many of them when I was working as a nurse in the labor room. From coming late to the labor room at late nights, insisting on normal deliveries due to familial pressures, though the baby was in distress. From the twin pregnancies, coming late to the hospitals with cord prolapse, but the mother was insisting on normal delivery, which was very difficult for us. The pre-eclamptic mother was not aware of the danger signs which she was in, and she had eclamptic seizures, and we had to take care of that, and she, unfortunately, the baby was not survived because it was too premature, and she ended up in the ICUs for almost 2 months. So these were the problems which I had observed, and I was thinking to myself, when I was working before 5 to 8 years in the labor room, these problems were there. And in our hospitals and here in KH, these are not so commonly seen. But when I recently went to an area for an awareness session, I heard from one of my close friend that in her area, there was a sudden death of the infant in postnatal ward, where no one knew. In the morning, they just found out that the baby is dead. The reason was unknown, maybe due to lack of monitoring, maybe the mother would not have observed that she was not woken up for the second hourly breastfeeding, and also the lot of teenage pregnancies, and they had come for abortions, which easily could have been tackled at community level by giving proper educations to the people over there. Especially those in that area, the laborers were more who were coming from north sides. So the teenage pregnancies were excess, where ANMs were handling the pregnancies at the level of in the community, where they were not being given proper family planning, proper education on those things. So in that manner, many people had septic abortions, and they had ended up in tertiary care centers in that area. So while seeing our nurses are the training is going on. The government is making a very good job in training the nurses at community level and even at our settings, especially nurse midwifery programs, nurse practitioners in midwifery is coming. And our college also has been talking to the council about the starting about nurse practitioner in midwifery. Also, as sir rightly said about the high fidelity birthing simulation centers, but it is not possible in every region of the area. Here it is possible, and our nurses are getting a good experience about it, and they get autonomy in decision making, as well as they can learn about before they go into real world situation, they can learn in a simulation area how to handle the emergencies in maternal emergencies, as well as postpartum hemorrhage, neonatal resuscitation, postnatal care. So all these things here it is possible, and many areas they have been doing that. But in remote areas, in slum areas, whether it is possible. When I was doing research in a slum area about this antenatal care, I visited mothers who had not even gone for one antenatal visit. They were having anemia, hypertension, diabetes when we checked there. And they said it is not a big thing. At home they delivered, before we had delivered in home. The elderly were telling that before this was all common, we delivered in home. Now it is not necessary. As well as that after a mother gets pregnancy-induced hypertension, soon after delivery, she forgets about it. She says that it will not affect her life later on. But we can see that many conditions arise. The pregnancy-induced hypertension is a risk factor for cardiovascular disease. So when we say we are not seeing the continuity of care from the antenatal period to the newborn to postnatal period of a mother. And here nurses, equipping nurses with, as they are the first point of contact, equipping them with good education, encouraging them with autonomy in decision making, especially in the community levels, in the remote areas, as well as continuous mentoring of those people. With nowadays, digital tools have been taking a great progress. So having digital tools with them, and here also they have been using those tools in monitoring pregnancies and monitoring mothers. The ASHA workers are also doing a great job. But some areas I have not seen any ASHA workers, only ANMs do, and they have a lot of workload as per se. And even the community-based interventions, where research also plays a very important role, where community context-based intervention should be given to the mothers, as well as how they can incorporate into policy the care of the antenatal to the newborn to postnatal care. And it was very sad that once during my postings that I saw a postnatal mother with depression admitted in psychiatry ward. But the parents of the mother had told that if we would have identified it earlier, we could have taken her to OPD and done a prior interventions rather than she ended up in the psychiatric hospital. So these are many ways, there are many ways in which we can prevent, and as sir rightly said that education is more and more important, as well as decision making, standing forward and speaking to the point that yes, we are right, we know the things, and it is necessary that now you have to refer the patient to an higher center is very important. Thank you, sir.
I think you have clearly mentioned the importance of decision-making capacity of a nurse. I think that is not often considered. I think that is so important, because with confidence, if a nurse can speak to the concerned party, that will make a difference rather than going around and then wasting time and all that. Let's move to nutrition, because we all heard about anemia, obesity, hypertension, hyperglycemia, which are all about what we eat or what we do not eat. So Ms. Hebbar, who is the coordinator for Center for Dietetics and Nutrition at MCHP in MAHE, please tell us about this most difficult topic of how to change diet, including all of the people sitting here.
Thank you for inviting me, and as you said, it's the most challenging, most difficult topic, nutrition. It's very easy to talk, but very difficult to practice. As we look at maternal anemia or obesity or hypertension, what we see across the pregnant women, the challenge what we have there is the way they are having their food, and when we have to counsel them on anemia or when we have to tell them about the obesity, it is easy for me to tell, and they take it, they listen to it, they say, yeah, we can do it and we will do it. But that should start. The actual teaching or the actual knowledge about nutrition should start in adolescence itself, because there is no point that they already are anemic and nutrition gets into it. It's very difficult to nutrition to act when they are below 7 or 8. Nutrition will never, it's not going to help them at any cost. So nutrition is only kept in mind where it is just to maintain the hemoglobin. So looking at nutrition perspective, the adolescent girls should be thought on it, and they should be given the importance of nutrition. Now what has happened now, everybody knows when we say you're anemic, the second question, you should eat lot of green leafy vegetables or lot of fruits. But how do you eat it? There are many inhibiting and enhancing factors. When you talk about leafy vegetables, all leafy vegetables will not affect. So how do you eat a leafy vegetable? That is more important than rather just telling them eat this, eat that. So that knowledge or that education is very much needed to all the mothers. So they should have a separate class, or they should be taught on it. See, this is the food you're supposed to eat. So when you tell a pregnant mother, you eat palak paneer, one small example, I would just like to put palak paneer here example. Everybody is fond of palak paneer. They say palak is a very good source of iron and paneer a very good source of protein and excellent food. But I should put it in this way, palak has good amount of oxalates in it, does not allow paneer to be, the protein in paneer to be absorbed. So it does not go good. So there's so many challenges in nutrition. It's more than telling them what to eat. It's always good to say how to eat. So what are you going to put in the food and how are you going to eat? So many pregnant mothers, they don't know, like when you advise them to take iron tablets, how are you supposed to take the iron tablet? We all know iron in presence of calcium is not absorbed. So that's one thing we have to tell them, like you don't take tablets with milk. You should, iron is best absorbed in empty stomach, but it's very difficult to take it in empty stomach. But at least with food where there is no enough of protein or calcium, iron should be absorbed. These are small things we should go on highlighting when you're talking about anemia. When you talk about obesity, yes, now we all know what is the reason. It's the kind of food they're eating. We always tell, eat what you were eating when you were small, the traditional food. There's nothing wrong in eating rice. Eat rice. You were eating rice, so eat rice, but the moderation. How much you're eating and how you're eating matters. The traditional food plays a great role, but most of us have forgotten about it. We see so many things coming up, saying oats, and so many other things, because I usually don't use that in my prescription, so I just don't think more about it. I say you're eating rice, you're eating ganji, you're eating what your mother has given you, jackfruit, mango, what is there in your nature, please eat it. But how you're eating it, that's a matter. How much you want to eat, that's important. So you should know. But that's one thing we're supposed to tell them, maybe more on whole grains, then whole fruit, instead of cutting the fruit and making a juice out of it, which is not needed. So easy way of eating, that's what has been seen in public or maternal mothers, I should say. And again, hyperglycemia. That's again the saturated food, the junk foods, what we are easy to make, ready to use. A little effort, I don't think so they are looking at. They want everything to be ready very soon and consume it. Exercise, they don't. One more thing which has gone into my mind is pregnancy. Nowadays, it's something, a different chapter. It's not that a natural way of handling it. If you're pregnant, something different, and you're something special. That's what is happening, and all these things happen because of these kind of lifestyle activities. That's what I should feel. Thank you, sir.
Again, quite a challenging topic actually. Globally, I think it is major, like 1 in 3 or 4 adults are getting hypertensive, 1 in 10 getting diabetes, and then adolescent onwards they're getting this, and then not only that, hyperglycemia in pregnancy, diabetic women are getting pregnant, which is even more difficult actually. Yeah, please.
Yeah. Now, as Madam pointed out, diabetes is a disease which has got, multifactorial. Basically, they have genes, and probably with ladies getting pregnant late, and they are into software or they are working, where they have some targets. They have to finish the targets. They don't have time to eat lunch, so they eat the junk food. They drink Pepsi. I'm not against Pepsi, but I'm just and that is where it comes into picture. And then stress levels are quite high. So all these genetics, along with environmental factors and your lifestyle, is going to precipitate. And that is on the higher side, because in the last 20 years there has been an increase in the number of gestation diabetes. That is one thing. And another anecdote I told you about iron. We had one patient where her hemoglobin was 9. We said take iron twice a day. Yes, then next time it had dropped to 8.5. And I said, how are you taking? No, doctor, I am taking it with glass of milk, iron and glass of milk. So I said, no, don't take it. But now what we tell is, you drink it with a glass of lemon juice. That helps us in absorption.
In fact, if you read the word deserts backward, it is stressed. So the more stressed you are, the more deserts you will eat. Okay, so Ritu, coming to you, you are a PhD student working on nutrition among tribal populations. So you have first-hand information on what is going through the mind of these women in these populations. It's in Nilgiris, right? Okay, so can you tell us very briefly what are their nutritional practices, and listening from Ms. Hebbar, what is it that we can actually do realistically, since you are trying to do that?
Thank you for this opportunity, sir. So just a small gist about my doctoral research. I'm working on the infant and young child feeding practices among tribal populations in the Nilgiris district in Tamil Nadu, basically Udupi and that area. So just to start with this, we actually have a preconceived notion. The tribal populations in India, their feeding practices are poor. Feeding practices as such, it is a big entity. We have a lot of components. We have initiation of breastfeeding, exclusive breastfeeding, timely initiation of complementary food, the appropriateness of that food, like in terms of its diversity, adequacy, frequency, all of these combined together is infant and young child feeding. For example, if we look at NFHS 5 data, 71.2% of the tribal children are exclusively breastfed, but only 11.2% of them receive an adequate diet. So we can't exactly say that tribal feeding practices are poor. So basically, tribal populations, they are inclined well towards breastfeeding. Their breastfeeding practices are fairly good in according to their cultural beliefs also. Also, they have enough social support, family support for breastfeeding. So these mothers don't go to work. For the first 2 years, they do not go to work. So breastfeeding is optimal. Also, institutional deliveries, which has increased through the coverage of, as ma'am has told, Janani Suraksha Yojana, and through home-based neonatal care, newborn care, it has been made sure that exclusive breastfeeding and even if not exactly exclusive breastfeeding, at least timely initiation of breastfeeding and continued breastfeeding, it is optimal in these populations. And here I have to say, as all of you have already mentioned, the role of community health workers like Asha and Anganwadi workers, that is of utmost importance. They are the major players for this in these areas. But there is something interesting when we look at the exclusive breastfeeding. Mothers want to exclusively breastfeed, but the problem with them is the nutritional status of the mothers, as we have already mentioned, it is poor. Because of that, they have lactation insufficiency. They do not alternate with infant formula. Instead of that, they start as early as 3 to 4 months, they start complementary food. So that is one main reason why the prevalence of exclusive breastfeeding is low in these populations. But again, complementary food, it is very much inclined, it is influenced based on their cultural practices, one, and their food security. Now, food availability, yes, all of them have enough food available from PDS, as mainly as rice and dal. So the mother is able to adequately feed the child. Adequacy only in the terms of frequency and quantity, but not diversity. That is the main aspect which is lacking in these populations. It is literally only rice and dal that the child eats. The child does not eat anything else. Well, sometimes all the 3 meals are only rice with nothing. Just rice as such is given to the child. So this diversity somewhat ICDS is trying to meet through giving a meal every day along with one egg every day. But again here another irony is the mothers believe that whatever the Anganwadi food is given, whatever food is given by the Anganwadi, that is more than enough to meet the nutritional demand of my child. So mothers, they do not put any conscious effort by themselves, and they cannot put the conscious effort also. We all have a notion that they all live very much near the forest, so they can easily access vegetables, fruits, green leaves. We have this notion, but we forget that there are invasions of animals. They have monkeys and elephants. So when I talk to the mothers, I'm like, why don't you cultivate something in front of your home, something like a kitchen garden setup? They're like, we do try. We do plant some green leaves. We do try. Monkeys do not eat those green leaves, but they just come, they uproot it and they leave. So it is not possible for us to do it. So basically, all around the past 5 decades, we have managed through ICDS with their interdepartmental and interministerial collaborations, we have managed to reach where we are now. But when we actually talk about tribal populations, it is important that we focus not solely on nutrition alone. So from the public health perspective, we have to manage their education, employment, living conditions, social support, food security, and along with all of these, health and nutrition intervention is the only way we can actually sustain whatever outcomes we have.
Very nicely put, Ritu. I think that 360-degree approach is needed, because we can't just take one aspect. It is an enabling environment. So talking about that, Dr. Arati, who is our Associate Professor at the School of Public Health, we have to sort of, we have PhD students here, but also large number of students also in community medicine and others. How can we impart this sort of skills rather than just being through biomedical approach? As we heard, it has to be a much broader approach. So what are your plans to sort of build those competencies in the students?
Good morning, everyone. Thank you very much for this, for being the brain behind this strategic discussion, a very important World Health Day with the theme of healthy beginnings and hopeful futures. So we just heard from the experts about what are the challenges, what are the gaps, how we can still do much better, and the other things. And we are in a situation where whatever was achieved before the pandemic, there was a little bit of rollback in the progress, and again, this rollback of humanitarian funding that's happening, which is critical to millions of lives. So I personally feel that the schools of public health have an important job in training these public health graduates, because these people, this cadre, the country needs, there is a huge demand for public health cadre, which cannot be met by medical colleges. That's what my opinion. So how do these MPH graduates help? They can serve as building bridges between the local communities to the healthcare system, and then help support the healthcare manpower that is there in the field, so to help deliver this maternal child health strategies, and mental health, listening to these women and their families, what are their needs, how the quality can be improved, and things like that. So having said that, then what is this task in hand to enhance the skills and competencies in these students? There are a couple of things which we need to focus on to build them, because in our School of Public Health only, we have these students from diverse backgrounds. Either they have taken up nursing or dentistry and physiotherapy and so many allied health sciences, but they have developed an interest in public health and enrolled themselves into Master of Public Health courses. Certain aspects which would be instrumental in the training of these students would be like integrated education and training. So what is this integration? So curriculum integration in terms of not just public health, but biological, medicine, nursing, midwifery, so that these interplay of factors like biological, social, climate, environment, all these things, the students get a perspective on. Second thing is, it should be a good mix of theoretical knowledge, practical skills, and real life scenarios and world case scenarios, so that these people, when they go out trained as public health graduates, they are able to deliver. So case-based learning and case-based approaches would be very instrumental to give this real-life experiences for the students. Collaborative projects. I think Manipal Academy of Higher Education serves as one of the right platform, because we have interdisciplinary institutions at walkable distances within the campus. I think this is an earlier situation in which projects of students of public health could collaborate with nursing, medical students, community medicine and things like that. So that gives them, learn from each other, and how they can deliver in the societies. The second thing would be like, apart from the theoretical knowledge, there should be immersion with the community. So these people should have, interacting with these communities to know the real life scenarios. Stakeholder engagement, policy makers, community leaders, they also have a big role when it comes to public health delivery. So we should have some workshops and conferences and stakeholder meetings when students can interact with them and come to know what it takes at the policy level decisions. Third important thing is cultural competency. These students, public health students, should understand how to respect the beliefs, practices. We cannot just go out there in the community and say what I say is right. Nothing works. So they need to have this cultural competency, and these opportunities for internships and dissertations. So help students to take up these projects in diverse settings, because we are just talking about Udupi. India is a land of diversity. Today we are talking about a global theme. So if you look at all of us, like we are just different, so as simple as that. So this has to be respected. Fourthly, skills. We are talking about mother and child health. As I said, these people come from diverse backgrounds. So what are these competencies? What is antenatal care, perinatal care, postpartum care? Someone was talking about postpartum hemorrhage. What exactly it is? So those competencies have to be delivered as far as the skills is concerned. Public health skills, how to conduct a research, data collection methods, epidemiological techniques, what is it required, interpretation, policy analysis, and most importantly, leadership and advocacy. How do they advocate for the rights and needs of mother and child? That should be a part of the curriculum. Now we have these days of innovation, technology, telemedicine, teleconsultations as far as mental care is concerned, and mobile apps, mobile applications. So students need to get hands-on experience of how to do this, because they might be later employed in diverse settings where this could be needed. And that's about. Then next we have simulated learning would be very helpful. Virtual reality tools, VR techniques, and clinical simulation, because there could be an emergency situation out there. How do I deliver? This is something the students should have a competency with. Policy and systems thinking, that is again very important, and then systems, health information systems, geographical information systems, how to map the problems, how to, you have to zoom in and you have to zoom out at the situation, however that is required. That is very important. And research and evidence-based practice. Public health students, it's very important, because subjectivity in public health doesn't work. We have to have objective evidence and evidence-based practice, and these students need to be trained about how to conduct population-based research. That's very important. And another thing very crucial is mental health. So when it comes to postpartum depression, anxiety, and again, as you said, what are the mental health needs of the families, of the mothers and the children? What are the coping strategies that's needed for this? They should have an exposure to this as well. Finally, evaluation skills. That's very important. Like, there are so many programs. We were talking about, those schemes, what works where, what are the outcomes of these various schemes, what are the gaps, and, how do we work? Implants and quality management strategies, and finally patient-centered care. This is so very important, because ultimately for a public health student, they need to know everything is revolving around this mother and child as a single unit. So these are important skills that needs to be imparted for public health students, would be my opinion. So thank you.
Thank you very much, Aradhi. I think we have come to the end of a very good panel discussion covering all aspects. I was thinking if we can have one or two messages from each of you, which I think you can speak in Kannada, because I think primarily if we beam it, it will be mostly in Karnataka. So maybe one round of a key message that you want to sort of give it to the people.
So in Kannada, if we have to translate this year's theme, that is Arogyakara Aramba Bharavaseya Bhavishya. So that means healthy beginnings and hopeful future. So with that theme, I think we need to, like as I mentioned earlier, that empower the parents and support the newborn, so that everybody has, because it's a fundamental right, it's not a luxury to have access to healthcare services or to have health. So everybody should have an access to this fundamental right, that access to healthcare services, and be healthy and build a healthy future for our country. Thank you.
In my opinion, I would say that no pregnant mother should die. That should be the aim of our community. As is, we should do all possible maneuvers to prevent that. If we start this, probably 5 years down the lane, we may achieve that.
ಎಲ್ಲ ನಾರ್ಮಲ್ ಮಕ್ಕಳಿಗೆ ಹುಟ್ಟಿದ ತಕ್ಷಣ ಆದಷ್ಟು ಮಟ್ಟಿಗೆ ಸ್ತನ್ಯಪಾನವನ್ನು ಕೊಡಿಸಬೇಕು ಮತ್ತು 6 ತಿಂಗಳ ತನಕ ಅದು ಕೊಟ್ಟರೆ ನಾವು ನಮ್ಮ ಮಕ್ಕಳಿಗೆ ಕೊಡುವಂತಹ ಉತ್ತಮ ಆರೋಗ್ಯ ಮತ್ತು ಹೆಲ್ತ್ ಇನ್ಶೂರೆನ್ಸ್ ಅದು ಆಗಿರುತ್ತದೆ.
So, as a government service, I want to tell only one thing. ಸೊ ನಮ್ಮ ಗೌರ್ಮೆಂಟ್ ಸರ್ವೀಸಸನ್ನು ಎಲ್ಲರೂ ಉಪಯೋಗ ಮಾಡಿಕೊಳ್ಬೇಕು ಅಂತ, ಯಾಕಂದರೆ ಗೌರ್ಮೆಂಟ್ ಆಫ್ ಇಂಡಿಯಾ ಅಥವಾ ಸ್ಟೇಟ್ ಗೌರ್ಮೆಂಟ್ ನಮ್ಮ ಹೆಲ್ತ್ ಡಿಪಾರ್ಟ್ಮೆಂಟಲ್ಲಿ ತುಂಬ ಇಂಪ್ರೂವ್ಮೆಂಟ್ಸ್ ಮಾಡಿದೆ. ತುಂಬ ಇನ್ಫ್ರಾಸ್ಟ್ರಕ್ಚರ್ ಇರ್ಬೋದು, HR ಇರ್ಬೋದು, ಟ್ರೈನಿಂಗ್ ಇರ್ಬೋದು, ಡ್ರಗ್ಸ್ ಆ್ಯಂಡ್ ಲಾಜಿಸ್ಟಿಕ್ಸ್ ಇರ್ಬೋದು, ಎವ್ರಿಥಿಂಗ್ ಎಲ್ಲನೂ ಫ್ರೀ ಇದೆ ಅಂಡರ್ JSSಗೆ. ಸೊ ಇಮ್ಯುನೈಸೇಷನ್ ಎಲ್ಲನೂ ಫ್ರೀ ಇದೆ. ಸೊ ಇದನ್ನು ನಮ್ಮ ಕಮ್ಯುನಿಟಿ ಪಾರ್ಟಿಸಿಪೇಷನ್ ಒಳ್ಳೆಯದಾದರೆ, ನಮ್ಮ ಕಮ್ಯುನಿಟಿಯವರು ಇದನ್ನು ಕರೆಕ್ಟಾಗಿ ಉಪಯೋಗಿಸ್ಕೊಂಡ್ರೆ, ಐ ಥಿಂಕ್ ದಟ್ ವಿಲ್ ಬಿ ಅ ಬೆಸ್ಟ್ ಥಿಂಗ್ ವಿಚ್ ಕ್ಯಾನ್ ಹ್ಯಾಪನ್ ಟು ಇಂಪ್ರೂವ್ ದ ಮೆಟರ್ನಲ್ ಆ್ಯಂಡ್ ಚೈಲ್ಡ್ ಹೆಲ್ತ್. ದಟ್ ಈಸ್ ಮೈ.
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. ನಾನು ಈ ಉಡುಪಿ ಕ್ಷೇತ್ರದಿಂದ ಮಾತ್ರ ಅಲ್ಲ, ಇಡೀ ವಿಶ್ವದಲ್ಲೇ ಏನೇನು ಆಗು ಹೋಗುಗಳನ್ನು ನಡೀತಾ ಇದೆ ಅಂತ ಗಮನಿಸ್ಕೊಂಡಾಗ ನನ್ನ ಮನಸ್ಸಿಗೆ ಬರೋದು ಒಂದೇ, ಸ್ವಾವಲಂಬನೆ ಇರಬೇಕು. ಇನ್ನೊಬ್ಬರ ಮೇಲೆ ನಾವು ಪರಾವಲಂಬನೆ ಬೇಡ. ನಮ್ಮನ್ನು ನಾವು ಇನ್ನೂ ಹೆಚ್ಚು ದೃಢೀಕರಿಸ್ಕೊಳ್ಳೋಣ, ಸ್ಪಷ್ಟೀಕರಿಸ್ಕೊಳ್ಳೋಣ. ಸೊ ದಟ್ ನಮಗೆ ಈ ಥರ ಏನಾದರೂ ಒಂದು ಚಾಲೆಂಜ್. ಈಗ ಉಡುಪಿ ಕ್ಷೇತ್ರದಲ್ಲಿ ತಾಯಿ ಮಗು ಆರೋಗ್ಯ ಬಹಳ ಸುಸ್ಥಿತಿಯಲ್ಲಿದೆ ದೇಶವನ್ನು ನೋಡಿಕೊಂಡಾಗ. ಆದರೆ ನಾವು ಇದನ್ನು ಹೆಚ್ಚು ಹೇಗೆ ಮಾಡ್ಕೊಳ್ಬೋದು. ಮತ್ತು ನಮ್ಮಂತೆ ಇವಾಗ ನಾವು ದಕ್ಷಿಣ ಕರ್ನಾಟಕದಲ್ಲಿದ್ದೇವೆ, ಉತ್ತರ ಕರ್ನಾಟಕದಲ್ಲಿದ್ದವರು ಕೂಡ ಎಷ್ಟೋ ತಾಯಿ ಮಕ್ಕಳು ಬಹಳ ಇಕ್ಕಟ್ಟಿನ ಪರಿಸ್ಥಿತಿಯಲ್ಲಿದ್ದಾರೆ. ಸೊ ನಮ್ಮ ಸ್ವಾವಲಂಬನೆಯನ್ನು ನಾವು ಮಾಡಿಕೊಂಡು ಕಾಪಾಡಿಕೊಂಡು ಇನ್ನೊಬ್ರಿಗೂ ನಾವು ಉತ್ತೇಜನ ಹೆಚ್ಚಿಸಿ ದೇಶದ ಎಲ್ಲ ತಾಯಿ ಮಕ್ಕಳಿಗೆ ಪ್ರೋತ್ಸಾಹಿಸೋಣ ಅನ್ನೋದು ನನ್ನ ಸಂದೇಶ.
ಯಾವ ರೀತಿಯ ಆಹಾರ ಅಥವಾ ಏನು ಆಹಾರ ತಿನ್ನಬೇಕಕ್ಕಿಂತ ಜಾಸ್ತಿ ಅದನ್ನು ಹೇಗೆ ತಿನ್ನಬೇಕು, ಫಸ್ಟ್ 1000 days ಅಂತ ನಾವೇನು ಹೇಳ್ತೇವೆ, ದ್ಯಾಟ್ ಈಸ್ ದ ಮೋಸ್ಟ್ ಇಂಪಾರ್ಟೆಂಟ್ ಡೇಸ್. ಸೊ ಹೇಗೆ ತಿನ್ನಬೇಕು, ಅದನ್ನು ಯಾವ ರೀತಿಯಲ್ಲಿ ನಾವು ಸೇವನೆ ಮಾಡಬೇಕು, ಅದರ ಬಗ್ಗೆ ಜಾಸ್ತಿ ಆಲೋಚನೆ ಮಾಡಿಕೊಂಡು ಅದರ ಬಗ್ಗೆ ಜಾಸ್ತಿ ಮಾಹಿತಿ ತಿಳ್ಕೊಂಡು ಅದನ್ನು ಮಾಡ್ಕೊಳ್ಳೋದು ಒಳ್ಳೆಯದು. ಯಾಕಂದರೆ ಈ ಫಸ್ಟ್ 1000 daysಲ್ಲಿ ತಾಯಿ ಮತ್ತು ಮಗುವಿನ ಯಾವ ರೀತಿಯ ಆರೋಗ್ಯ ಇರ್ತದ, ದ್ಯಾಟ್ ಫೌಂಡೇಶನನ್ನು ಏನು ಹೇಳ್ತೇವೆ ನಾವು ಮನೆ ಕಟ್ಟಲಿಕ್ಕೆ, ಇದೊಂಥರ ಹಾಗೆ. ಸೊ ಆ ಫೌಂಡೇಶನ್ ಸರಿಯಾಗಿದ್ದರೆ ಐ ಥಿಂಕ್ ಸೊ ನಾವು ಎಷ್ಟೋ ಕಾಯಿಲೆಗಳನ್ನು, ಮೇ ಬಿ ಡಯಾಬಿಟಿಸ್ ಆಗಲಿ, ಹೈಪರ್ ಟೆನ್ಷನ್ ಆಗಲಿ ಅಥವಾ ಒಬಿಸಿಟಿ ಆಗಲಿ, ಇವುಗಳನ್ನೆಲ್ಲ ನಾವು ಮುಂದೂಡ್ಬೋದು. ಸೊ ಆದಷ್ಟು ಆಹಾರಗಳನ್ನು ತಿನ್ನುವ ಮುಂಚೆ ಹೇಗೆ ತಿನ್ನಬೇಕು ಅಂತ ಅದ್ರ ಬಗ್ಗೆ ಒಂದು ಮಾಹಿತಿ ತಿಳ್ಕೊಂಡು ತಿನ್ನೋದು ಒಳ್ಳೆಯದು.
ಪ್ರತಿ ಅಮ್ಮ ಮುಖ್ಯ, ಪ್ರತಿ ಶಿಶು ಮುಖ್ಯ. ಪ್ರಶ್ನೆ ಕೇಳಿ ಉತ್ತರ ಪಡೆಯಿರಿ. ಸೊ ಇಫ್ ಐ ಹ್ಯಾವ್ ಟು ಟೆಲ್ ದಿಸ್ ಇನ್ ಲೋಕಲ್ ಲ್ಯಾಂಗ್ವೇಜ್ ಆರ್ ಮೈ ಮದರ್ ಟಂಗ್ ಆಲ್ಸೋ, इसारा आणि तुमका आणि तुमचे हेल्थ विषय तुम्ही केदाळरी आन्सर घेया. So this is what I have to tell, that every time you ask a question about your health and demand an answer from them. So that's it.
So I would like to tell something to the public health workforce. Tribal people as such, they have relatively more exposure to non-tribes at present. So we first have to ensure that we build proper rapport with them. That is the only way that they will listen to what we say, they will understand. But they are willing to improve their living conditions. So it is better to build rapport first, and then it will help us to improve our outcomes.
Thank you, everyone. I think they all need a big hand. I'm sure in 1 hour you have heard more than what you can learn in 1 month from these experts. So I think it has been an excellent panel. Thank you, everyone, for taking the time out on a very busy day and be with us and to observe this day. Thank you very much, and let's keep working on this. Thank you.